There we go. Now we're recording. Okay. So I just gave you a little tidbit there again because you were with me. Here we are. Where are we? Here. Brain teaser. Here we go. So that's why we put a Foley catheter in. It's because we don't want to damage the bladder. Because when you damage the bladder, then we have to get a urologist to come in the operating room to repair the bladder. And then you got more problems than you want. So we always want to make sure that we don't damage the bladder. So that's why we put a Foley catheter in before a cesarean. Make sense?
Yes.
Yeah, it makes sense. Yeah. Okay. All righty. All right. So let's go ahead and we're going to talk about abnormal labor and some labor delivery complications. And let's see what our first one is. So this is called abnormal labor. All right, so we went over Monday what normal labor should be, and that should be like contractions every 2 to 3 minutes, lasting 60 to 90 seconds in duration. So now we got this what we call abnormal labor. These are reasons for having to do a cesarean is that maybe mom has been in labor, okay, and we're trying to get her into a nice undulating, normal labor pattern, but it's just not going that good. It could be that maybe the baby is big and we just can't get her into a pattern. Okay. So she doesn't progress like we want her to. And so she gets stalled. Sometimes they get up to like 6 centimeters. Can you imagine? 6 centimeters, and no matter what we do, she's not moving past it. That's a difficult labor, and that's what we call dystocia, and that's right there is dystocia, and that's called a difficult labor. Okay, so that's another reason why we have to do a cesarean is because she's just not making progress. That's why the other day we talked about amniotomies. You know, doctor comes in and he says, "Oh, she's not making progress. So what I'm going to do is I'm going to go ahead and break her bag of water because we got to get this going." They do that a lot of times because we don't want her to stall out. Contractions are the power of your contractions. That is caused by the fundus of the uterus contracting. Okay, muscle contracts. Remember, the uterus is made up of 3 different muscle fibers. They're all going to contract. So when that stops, then we don't have progression of labor. Makes sense. So we can have problems again with the powers of labor, those contractions. One, they can be too many. We talked about that. Hypertonic, too many, hyperstimuli, hyper tachysystole. They're all the same. They mean too many contractions, hyperstimulation of the uterus. Not good. Or you could have too little. You could have what we call hypotonic, where the contractions really spread out. And no matter what we do, we don't seem to be able to get them to be regular. Now, this poor lady in this picture here, I chose this because it shows that, she's in the labor room and she's dealing with contractions and she's breathing with those contractions. And that's another one, too, that you have to support your patient when they're in labor and help them breathe. Because sometimes, the contractions can grab them so hard and they forget to breathe. I always tell my patients, come on, let's breathe. Take some good deep breaths in and blow it away. Breathe in, blow it away. And when you do work with your patients like that, they
Hello?
respond nicely.
No,
Yeah.
in class, online class.
Pardon?
Winnie mute.
Winnie, what'd you say?
She need a
Oh, all
mute.
right.
Okay. All right. So here I thought this was really good for you to see because here's oxytocin. Remember, it's secreted by, released by the pituitary, and it's a natural hormone in the body. And that causes what? Contractions. And when you have contractions, you have cervical stretching. That's why it's pain. Labor is very unique pain. And they talk about that in chapter 7, how pain is very subjective. Like my pain, I mean, I have a good tolerance for pain. So I may be having contractions, but I'm not saying anything. Maybe Winnie is having contractions and she's deep breathing and blowing and everything else, right? Her pain tolerance, her threshold is different than mine. Everybody's different. So we treat everybody as unique as they are. And usually, when I get a patient in labor, I have a good discussion with them as to what they desire. You know, we talk about pain relief. And so I know if she wants an epidural, or I know she doesn't want any intervention, she doesn't want any epidural, then fine. Then we'll go with what she wants, right? Sure. Until about they get to about usually about 7 centimeters, and they yell for the epidural. Okay. All right. Um, Pushing. You know, when a woman becomes completely dilated, you know, then she's done with the first stage of labor, then she goes into the second stage of labor where they start pushing. And pushing, you have to be effective. So, you know, it can be very tiring for somebody who's pushing. And if it's a big baby, it can take longer. If the baby is the head is in occipital anterior, that means that the back of baby's head is facing mom's front. If that is the head is tucked down nice and deep. So take your head and just put it down to your chin, and you see the back of your head here, like I'm pointing to my back of my head. I would be pointing to mom's front. See? You see, everybody see that? Okay. So that would be an OA position. That's the way we want babies to come out. It's OA. Then the pushing stage is not so hard. It's a lot of work, granted, but if you have a baby who is OP, that means again, I'm going to point to my head. The occipital, which is the back of my head, is now pointed to mom's back. Then I'm going to be in a different position. My chin's going to be up like this. See? And that is so hard to push. And when, you know, epidurals are great during labor for pain management, but when it comes to pushing, it makes it difficult because you can't feel. And you can't feel, then you push everywhere else but what? In your bottom. And so usually when my patient becomes completely dilated, we let up on the medication that's delivering for the epidural. So she gets a little bit of what we call friendly pressure. And then she can feel just a little bit down in her perineum there. So she can feel where the baby, you know, she needs to push in order to what? Deliver. Okay. So epidurals are great for pain during labor, but when it comes to pushing, it makes it harder for the patient to push. Okay. Now, one thing about I want you to write down with epidurals while we're discussing a little bit about epidurals here is that epidurals mom has to be monitored very closely. So does baby. Mom's blood pressure can decrease with an epidural. So mom's blood pressure can decrease with an epidural. So therefore, what we do is before we give the epidural, we'll hydrate with at least 1,000 ml of lactating ringers, and therefore give her some more volume. And, you know, therefore I'm going to increase her blood pressure so that when she gets the epidural, the body can like withstand it. It kind of evens it out. And so I don't have a problem with mom bottoming out, and I don't have a problem with baby bottoming out because I want to keep them both in the normal range. So that's what we do. So write that down because you'll probably see that again.
You said hypertonic?
Yeah, hypotension is what happens when a mom gets an epidural very easily.
And you said hypertonic solution?
We
Latte
use
ringer.
we use lactating ringers.
Oh, lactated ringers. Okay.
Yes,
You say
ma'am.
how many ml?
We usually hydrate. Now, anesthesiology will tell you how much, but normally in a normal patient is 1,000 mLs of LR, lactated ringers. Okay. All right. Another problem why we may end up with a complication during labor and birth is the problem with the fetus, the passenger. Remember, the fetus is the passenger. Remember, we talked about baby maybe being too big. Maybe he's in an abnormal presentation. Maybe he's breech, and so therefore, we don't really deliver breeches vaginally. We go ahead and take them out cesarean. So that could be a problem. So again, maybe he's OT, where the head now is transverse in the pelvis. So when you have a head that's transverse, he's not going to be able to fit through the pelvis like he should, and therefore cause a problem. Therefore, maybe mom won't progress because his head is not helping put pressure on the cervix, so they end up doing a C-section. So those are things that can complicate a woman's labor and cause her now to have a cesarean rather than the vaginal birth. Okay, all righty. Let's do a little brain teaser here. So what will the nurse anticipate assessing in a client following a cesarean delivery? So your patient is in the recovery room. What do you have to be careful of? What do you have to be watching?
Blood pressure.
Yep. So all the vital signs, right? Blood pressure, pulse, respirations, right? Temperature. Okay, all her vital signs. Okay, you're in the recovery room. What else do I have to worry about? You just had this baby. How about the uterus? Remember, we got to make sure the uterus stays nice and firm. Even when it's a cesarean, I'm going to gently use the side of my hand to kind of make, can you see my hand? I have it like in a cupping position here. And I'm going to put my hand on top of the fundus and make sure that it stays nice and firm. So that's my fundal assessment. I'm going to monitor her IV, right? So I'll have her on a pump. And then I have a Foley catheter, so I'm going to measure her urinary output. What goes in? Remember something. What goes into the body comes out, okay? So I'm going to do her intake and output. Lochia. What's lochia, guys?
The blood, right?
Yeah, the drainage, blood drainage. So I'm going to see how much lochia she's draining. So that should be lochia rubra, because rubra, R-U-B-R-A, is the first 1 to 3 days after having a baby. It's lochia rubra. Okay, so I'm going to look at the lochia. I'm going to look at her incision dressing. She's got a dressing on her abdomen. She just had surgery. So I'm going to look at the dressing and I'm going to see if there's any little spots, that means maybe she bled a little bit. And so what I remember I said I told you the other day is you can do this on any surgical patient. You got a pressure dressing on. You don't remove the pressure dressing, but I will do I'll put a little circle around that spot. And what I do in about 30 minutes, I'll reassess my patient again, and I'll look at that little circle. And if I see drainage outside the circle, I know that she's bleeding a little bit more underneath that dressing, and then I report that to the physician. So this is what you're anticipating. You're looking at a patient who just had a cesarean delivery, and you're in that recovery room. Okay. Alrighty. So a baby who has an abnormal fetal presentation, Sometimes we like to turn those babies. Oh, nurses, we get very creative, let me tell you. So, we'll have patients sitting, kneeling, standing. A lot of times when my patient wasn't like in the beginning of labor, she was maybe in the latent phase of the first stage of labor. I would have, and she was tolerating, oh, she got back pain. Oh my gosh, she said, Irene, I have such back pain. So what I do is I'm going to have her like lean forward. So I get the bedside table and I put a pillow on it. And then I tell her to lean forward over the bedside table. She can lay comfortably on that pillow. And that kind of stretches the back out. It does feel good. And then I can use, remember, my palm of my hand on her lower back, on the sacrum, and give her what we call counter pressure. Write that down. Counter pressure. And it just feels really, really good on her low back. And then she's stretching out. And that really helps sometimes to rotate these babies. Babies like to start in an OP position in the beginning. And then as labor, the contractions get stronger and stronger. It helps to turn those babies during the time. Okay, and then we do sometimes rocking back and forth. We have a little rocker and we tell them to rock. Or sometimes sometimes we have to put the mom in on all fours and let her try to turn the baby around that way. And so those things are good. We always put them in a sideline position, never put a patient on her back, never in the supine position. Squatting is good. They can tolerate that. Squatting is good. And I put here in the second stage of labor because squatting helps to open up the entire pelvis and let that baby come through. And if she's pushing, that really helps. And then, of course, we can do like lunging and all that. And what your role is basically really is to, assess your patient. This is a video. It's on a breech. I hope you take a few minutes and watch that. It shows you a breech delivery. Okay, so let's go on to twins. Twins is another problem that can cause a dysfunctional labor because the uterus now is so extended because it had to be to house both babies. And one thing you worry about this is that most of the time for twins is that we will do a cesarean, but maybe you have a gravid of 5, here of 4, and now she's having twins, and she has a pretty good pelvis, gynecoid pelvis, I should say, and these babies, she's proven that she can deliver big babies because she's gravid of 5. So sometimes they'll deliver those kind of patients with twins vaginally, and sometimes one could be in a vertex or cephalic position. That's what that is. And the other one could be in a breech. So a lot of times they'll go up and they'll turn that breech into a vertex presentation. Mom pushes the baby down. So, it's a little stressful time, I have to say, but it's wonderful. And when they both come out that way. So I just wanted to show you in this picture. I thought this was a really good picture. This is a really cadaver hair, but this is a bony pelvis. And what I want you to take note is look at this coccyx right here. This bone. Bones, they don't move very well. And when you have a lot of pressure and have big babies, they can fracture this. And I've actually had a patient that did have a fractured coccyx, and she actually went to close to term, but she was in a lot of pain. So I just wanted to show you that. And always remember psychic, the how mom is feeling about the labor. And if she by herself, that also can hinder labor, hinder her from dilating. It's always nice to have someone with you. When you have somebody with you, it helps to control that pain. And then of course, if you're restricted to bed, if you're if you're pre-eclamptic, those are kind of patients we can't have out walking the halls or anything because of blood pressure and they're on magnesium sulfate. So they really can't be walking the halls. But we can, turn them from side to side, maybe get them up at least sitting a little bit and things like that. So the psychic. So I put in here, this is a typical L&D room, and the rooms are so much nicer today than they ever been. And you can see the birthing ball here. We have everything we need. We may have a pool bar, and we have nice furniture in there too. Okay. I just wanted to show you that to kind of give you a picture of what to expect. All right. So the uterus needs a lot of energy. So the uterus uses a lot of glucose for energy during labor. The uterus too, a lot of blood kind of is diverted from the uterus during labor. There's increased tension of pelvic muscles. So we want to keep her what? Relaxed. And that's why I say the epidural works so wonderfully, is because it relaxes the pelvis so beautifully and able to get that baby to descend. Okay. A lot of times, if we talked about this already, and this is just a term you might see is abnormal duration of labor. That just means that she's been in labor a long time. And I have a picture here. This is a typical fetal monitor. And on this right here, where I got you can see my little arrow, my pointer. This is contractions. And then here on the top here, and that's the fetal heart rate. That's the printout for the fetal heart rate. So we're monitoring the baby and monitoring mom's contractions so we can see how baby's tolerating the contractions. Now, this is a term that you might see again, everybody. It's called a precipitous birth. And basically what that is a birth that she labors and dilates and delivers all within 3 hours. Okay, so it begins very suddenly, very abruptly. Maybe you see this in movies a lot. On TV they like to do this. Mom goes into labor all of a sudden the bag of water breaks and labors intensify, and she's boom, boom, boom. She's having one after the other contractions. We call that what? Uterine tachysystole. And they're very intense and very frequent. And then all of a sudden she delivers. Well, remember, it has pluses and minuses like anything else. So the plus is that she gets done really quickly, but the minus is, one, she could have a uterine rupture from that uterus contracting way too frequent and very intense. She could have a laceration of the cervix because the baby's going to come very quick. Because the baby's being pushed by the power, the contraction. And so she could tear her cervix up, or worse, she could have a hematoma. And remember, we talked about hematomas in the vagina. They're very, very, very painful. Very painful. Baby can have injuries. Baby coming down the pelvis so quick, he's going, wow, this is a really wild ride. And he could have maybe intracranial hemorrhage. And he could have some nerve damage due to the fact that he came down so quick. So, maybe it's not so good, that doing all this so quickly, because things can happen. So how about we do a little brain teaser? So this could be a good question, because going back here, she's having all these labor intensifying, and the uterus is contracting so fast that the uterus, just like any other muscle, is going to say, boy, am I tired. And so after you deliver, you want that uterus to contract so that she doesn't hemorrhage. But if you're having all these contractions, one after the other, okay, then she could have a problem where after delivery, the uterus doesn't want to contract anymore. It said, I had enough, I'm tired, and I'm not going to contract, and she could hemorrhage. So if I ask you a question such as this, what type of complication now could occur after precipitous delivery? Could it be an infection? Could it be a hemorrhage, diaphoresis, or hyperglycemia?
Hemorrhage.
Hemorrhage, exactly. You got it. Okay. Very good. Yeah, because remember the uterus is going, I'm done. I'm tired. And it does not contract as effectively. Okay. So now we're going to go into ruptured membranes, and we patient will rupture them prematurely, and that's called premature rupture membranes. So sometimes they rupture a term, which you see a lot. More often, more than an hour before a contraction begins. Yeah, remember in the movies they always show the lady standing somewhere, and all of a sudden she goes, woo, and there's a little puddle on the floor. That's rupture membranes. So how are you going to confirm that she has rupture membranes? She comes into your hospital. You got two ways. The one easy way is that you can do this. It's called nitrazine paper. And nitrazine paper is a litmus paper. And what it does, it turns a dark blue when it's positive. So that's an easy way to see it is with nitrazine paper. If it doesn't turn like a bluish green, then it would still remain yellow. Then she's not ruptured. So it changes color when the pH now has changed, and so therefore now affecting the litmus paper. Real simple. Anybody can test for that way. Otherwise, you're looking for maybe a little more in-depth testing. That's called a Fern test. And what we do as RNs, we'll go ahead and put a speculum in, and we'll get a little bit of the fluid, and we'll take it on like a little sterile Q-tip, long Q-tip, and a sterile, of course. And then we'll put it on a slide. Okay. And a lot of times I'll look at under a microscope, and I look at the slide, and I see a fern, an actual fern. A fern that you would see, outside, green ferns. Well, now I'm seeing a fern, and that definitely is the ruptured membranes. So that's just something that I wanted to tell you. All right. So what am I going to do if she has premature ruptured membranes? And now we're going to basically hold her off for maybe a day or two, or as much as we can. But I got to monitor this woman, and sometimes LPNs can work on this unit, and you have a woman with ruptured membranes, and we're going to monitor her and see if she'll go into labor, or we want to get more time for the fetus. So we're going to watch her very, very closely. We're going to watch her temperature. 100.4 greater, we need to be on our toes, right? Nothing in the vagina, okay, because I don't want her to get an infection. You avoid breast stimulation because basically that's what can put her into labor. Maybe we don't want her in labor. Maybe we want to get a day or two more or a week out of this. Sometimes if they rupture early, like maybe they're 32 weeks gestation and they rupture early, and they're not a big rupture. Okay, it's a small rupture. Sometimes that will seal over, and we can keep the baby in utero for a little bit longer. So this is the kind of situation that you might see this in. Definitely going to restrict all kinds of activity. This is not the patient that goes out walking. Okay, I want to keep that baby in maybe utero. I want the bag of water to seal over. So again, nothing in the vagina, and she's not going to go out walking. No stimulation to the breast because that could cause contractions, put her into labor. I'm going to monitor her. I'm going to monitor this baby very closely. And I want to make sure that the baby's moving. So I'm going to tell her, I want you to tell me if you don't feel this baby moving during the day. If you have fewer than 10 kicks, okay, in a 12-hour period, that's not good. So again, I'm going to watch her very closely, And again, just like I put down here, premature labor is defined as the onset of labor between 20 weeks and 37 weeks. Okay. All right. Let's go on here. These are just some exposures, some risk factors that expose preterm, that puts a patient to preterm labor. And let's see, when we talked about nutrition, we talked about chronic illnesses before coming into the pregnancy. Dehydration is a big one, especially where I live in Florida. People, especially during the hot summer months, they get really, really dehydrated. They go to like the Disney guys, and they're spending the day in Disney, and then sure enough, it's hot. It's like 100-degree weather, and that they can't drink enough to keep up with the dehydration. We see them in the hospital for preterm labor. Preeclampsia can throw them into preterm labor. If they've had a previous preterm labor or birth, we're going to be on alert. Remember that GTPAL? We go over how many babies they've had and how many are term, how many are premature. This is why is that we want to keep tabs on her. If she could be prone to going into preterm labor again. Okay. And then any kind of pregnancy losses I need to know about. Substance abuse, of course, can throw them into preterm labor. And of course, stress, our single parent or adolescent who are under a lot of stress can go into preterm labor more so. So, and then of course, infection, anemia, if they had premature rupture membranes, can throw them into preterm labor. Let's see here. If they're not eating well, have low education level, all that kind of goes into the fact that they're not getting prenatal care like they should. Maybe it's low social economic area, and they're not getting what they need to get. And then of course, if they have multiple fetal twins, triplets, those patients can go into preterm labor very easily. And the reason why I think about it is because the uterus is so stretched, okay, that it can make that uterus get cranky and start contracting. All right, let's go on here. So I always say this. All right, so if we're looking at someone and we're trying to see if they're going to be going to preterm labor, we have a couple things. And I'm going to just share this with you so you're aware of it. And it really is a neat test. It's called the fibronectin test. And we can do this. Patient comes in and she's maybe she's been contracting a little bit. Maybe she has a history of preterm labor. We can do this test. And it's usually between 22 to 24 weeks that this fibronectin is secreted in the vaginal secretion. And this gives us a clue if she's going to go into preterm labor. Now, that's pretty neat. Before this, we didn't have anything years ago, but this has been around for a little bit now. And what it is a protein that's produced by the fetal membranes. And what happens, it actually leaks into the vagina a little bit and through the vaginal secretions. And so, she can go into preterm labor, and then, you do those little tests, and sure enough, if it comes up positive, then we know that maybe we need to start her on what we call a tocolytic, which is a drug such as magnesium is a tocolytic, and so is, what's the other one? Brethine, terbutaline is a tocolytic. Okay. So these are things that are really helpful to let us know, and then we can plan a little bit. Now, also, a patient comes in and she's dehydrated and she's contracting, and she is maybe 32 weeks gestation. She's in preterm labor. Okay. I want to stop her as soon as I can. Because when a patient dilates like to 2 centimeters, getting past 2 centimeters, and they get a face, that means the cervix gets real, real soft, such as the maybe 80% efface, it's hard to stop. And so if my patient came in and I checked her and she was 1 centimeter, 50% efface, I want to, but she's contracting and she's early. I want to stop her as soon as I can. I'll get a call report real quick and get some orders for IV, get her hydrated very, very quickly, and that helps stop the uterine contractions. A lot of times, sometimes they'll tell me to use terbutaline, and I can give that sub-Q, or we'll start her on some magnesium sulfate first, which was relaxes. Remember, magnesium relaxes the muscle fibers, and so that would help her. The main thing about preterm labor is to stop it quickly before they get dilated. All righty. This just goes over some symptoms of what a patient would be experiencing if they were in preterm labor. Remember, they may not be having rhythmic contractions, but they maybe have a constant low backache. A lot of times they'll say it's like menstrual cramps, abdominal cramps. Sometimes I just don't feel well, nurse. I had a patient that was severely, I think I said this to you, severely constipated at one time. And she felt, she was having contractions. And she was early gestation. And I checked her real quick because, I'm going to see how much her dilation was. Remember, she's preterm, so I want to get her, I want to stop this as soon as I can. And sure enough, I could feel in her colon, I felt little stones. Okay, she was severely constipated. So I said to her, when was the last time you had a bowel movement? And she said, oh, nurse, I've been having such problems with this. So I called the doctor, got an order for an enema, and she stopped contracting. She felt so much better, and she went home. So things like that can happen. Now, this slide here goes over the tocolytic therapy I've been talking about. And I would really want you to know tocolytic therapy, okay? Because this is to stop contractions. That's the goal, is to stop the contractions. Toco is a word for what? Contractions. That's why as part of the monitor is called tocodiameter. And so toco, just remember contractions. So this is therapy. This is therapy to stop the contractions. And it could be magnesium I talked about that helps to stop it. Also some breathing or terbutaline. Okay. But these are contraindications to tocolytic therapy. And I know there can be questions that can come up where, well, what would be a condition that patient could have that would be contraindicated giving her tocolytic therapy? Well, if you have preeclampsia, you're not going to give tocolytics because tocolytics have a tendency to increase mom's heart rate. So you wouldn't give that to a tocolytic. Placenta previa, abruptio placentae, again, because increased pressure, increased heart rate, and gestational age over 37 weeks. Well, she's term. 37 weeks is considered term, so I don't have to stop her. She's here, tocolytic. I can use that. I can have it delivered. Excuse me. And this is chorioamnionitis. This is infection of the choreo and amnio. Remember we talked about these layers of the uterus. If she has an infection, we have to get the baby out. So I wouldn't stop her from delivering. And of course, the fetal demise, we want to get the baby out. So stopping preterm labor, I talked about this already. Hydration, okay. restrict activity, and then check temperature to see if she has any kind of infection going on. A lot of times too, they come in preterm labor because they have a UTI. And so, the bladder lays right underneath the uterus. And during the pregnancy, sometimes mom can be a little messy and not wipe correctly, and she happens to get a UTI, and that causes that uterus now to contract. That's why we go over self-care, proper ways to maybe have hygiene, is so that we keep her from going into preterm labor from a urinary tract infection. That's why we'll monitor her urine when she comes into the office all the time on her visits, is because we don't want her to have it. Sometimes it's just inevitable that they will go into they will continue to be in labor, and we can't stop. Remember I said 2 centimeters and greater effacement is hard to stop somebody from delivering. So if it's gonna happen. I can't stop her. I can help the baby to have better lung function at birth. So what I can do, now write this down. This is an important concept. So betamethasone is a steroid. And I can give mom who's in labor with preterm labor, give her an injection of betamethasone. So it'll be like 12 milligrams, 24 hours apart. So it'll be 2 injections, but 24 hours apart. 24 hours. Not 23, 24. And so this here will help increase the production of surfactant in the baby's lung. Okay, so surfactant is what you need to, remember we said to inhale and exhale. It's like the grease, in and out, in and out. If you don't have enough of that, then the breathing gets a little bit more slower. It's not so effective for respirations. So, but if you have a surfactant, it's easier. See. And so we want to make sure that the fetal lung is mature at birth. So what we're going to do is we give her the betamethasone to help that, especially we give it to pretermers. So that's an important concept. So I hope you got that. Write it down. And so, and that's where sometimes if they have that, remember I said that premature rupture membranes, sometimes we know that they're going to deliver and they're early. So what we can do is we'll monitor mom and baby like we discussed, and then we'll give her betamethasone and try to get a day or 2. And so that when the baby's born, he has a better chance of breathing on his own. So with that surfactant. So write that down, surfactant. Alrighty. We talked about preterm quite a bit. Now we got prolonged pregnancy. And that's pregnancy that lasts longer than 41 weeks. I get into 42 weeks and I get a little bit nervous with my patients because everything tends to get old, such as what? The placenta. The placenta gets old. It starts to calcify. Ever see, something that, is old, like old furniture outside, say, and you see that it gets that kind of crusty looking stuff on your furniture. That's all calcification. It just gets old. It won't pump like it should. Okay. It won't deliver the oxygen to the fetus as it should. So what happens is that babies tend to even lose weight in utero. Their skin, when they get like real, they're done. At 42 weeks, you're supposed to be done, honey. So their skin starts to peel because remember that Vernix caseosa is nature's cold cream. And so the baby has enough to get him through to like 40, 41 weeks. But when you get past that, it doesn't, he doesn't have any more. He kind of uses it all up. And so his skin starts to peel. It's not so pretty when they're born, when their skin is just peeling right off. And then a baby can also get bigger, okay, because he's in there too long. So that can happen. So then you get a real big baby. And baby also can have his first bowel movement in utero, and that's called meconium stained fluid. And meconium, when you have it in utero, when baby passes meconium in utero, it has to be treated as soon as the baby's head emerges. And you have to suction that baby out. You can't let that baby take his first breath, because when he does that, he would what? Aspirate. He would take in his excuse me, the meconium, and he could aspirate on the meconium. And then you have a sickness in an infant called aspiration meconium syndrome, the meconium aspiration syndrome. And so that's not good. So meconium can be passed because now the baby is getting old inside. So then these babies, when they come out, have a tendency to be hypoglycemic. They have a tendency to have low blood sugar. Okay? So they can be sick babies when they come out. So you have to be very careful. So a lot of times I get kind of nervous with my patient when they go 42 weeks. All righty. Now these are tests that can, if we're going 41 weeks, 42 weeks, we can do these simple tests to make sure the fetus is okay. And one of them is called a non-stress test, NST. Now write this down. Non-stress tests, they're not invasive. All you do is put the monitor, you put the ultrasound transducer on, you pick up the fetal heart rate, and you put the toco on to pick up contractions. And then what you do is that you give mom a little buzzer, and when she feels the baby move, she presses the buzzer. Okay. And then what we do, we just correlate to see, okay, baby moved, baby's heart rate went up. That means we're good. Baby moved, but heart rate went down. Not good. Baby didn't move at all. Not good. Babies should be always what? Moving, and their heart rate should be what? Going up. So that's an NST. Another one we can look at is a biophysical profile. It's an ultrasound, and we're looking at different parameters such as respiration, heart rate, movement, pockets of fluid, and see how much amniotic fluid still is there. We call that the amniotic fluid index. And then we make sure the baby's moving. So we tell mom to keep tabs on how this baby moves. And she sees that the baby's not moving, then she's going to come right to the hospital and we're going to assess the baby. Okay, we got a few more slides. This one is on emergency during childbirth. Okay, we talked about prolapse cord before, where the cord comes actually down, and the cord is actually presenting in the pelvis, and then the head is above that, okay? And so the head, when it presses down right on the cord, and therefore decreases oxygenation to the fetus. Babies can die because of prolapsed cord. So it is a medical obstetrical emergency. We have to get that baby out very, very quickly. A uterine rupture, we talked about that, where the uterus can actually rupture, maybe due to hyperstimulation of the uterus, such as we talked about precipitous birth can rupture a uterus, where A woman I told you one time came in. I put the fetal heart rate monitor on, and fetal heart rate was real low, like in the maybe 90s. And we took her back. We opened her up, and there was the baby. It was outside of the uterus, floating. Her uterus had ruptured wide open. She could have been having a. She could have had a C-section. And then she started contracting. She didn't go to the hospital when she was told to go, and she ruptured her uterus ruptured because of the scar on the uterus from the cesarean. That anytime that you do a surgery on an organ, you're going to make that organ weaker. So on the uterus, when we cut into the uterus to get the baby out, we are actually making that uterus weaker for the next baby, right? So we want to make sure that because we sew it up really, really well, believe me, we do, but it can rupture. And then you could have another like dehiscence, they where it just opens up. Okay. All right, let's see what the next one's showing here. Yeah, amniotic fluid emboli. And I think I talked about this already the other day, but I'll just go over it because it's in this chapter also. It it happens when amniotic fluid, and sometimes amniotic fluid has like we call vernix, which is the baby's cold cream, and has fetal hair, which is like lingongo. Sometimes baby had meconium in utero, so now meconium is in that amniotic fluid. And what happens is that the amniotic fluid enters mom's circulation, her bloodstream. And what happens, it travels and it blocks off like small blood vessels in her, especially in her lungs. Okay. And it's not good when amniotic fluid circulates through mom's bloodstream. No. And what happens to mom, she can have an abrupt onset of hypotension. Her blood pressure go down. She'd go into respiratory distress, and she can bleed out. Which now she has what we call a coagulation abnormality from the thromboplastin that's in the amniotic fluid. So I think I told you I had a patient that I labored all day with, and she didn't make progress. She had dysfunctional labor. We took her back for a cesarean, and everything was going good for the cesarean. There was no key, nothing was happening. A baby came out, and we were sewing her up, and husband was like over in the corner with the baby, and she she couldn't breathe. Her vital signs went haywire. Her blood pressure went down, and her heart rate shot up. She was, trying to breathe and everything, but she couldn't. She went into respiratory distress, and my patient did die on the table. So it was caused by this amniotic fluid emboli. Just like any other emboli, it can cause death very quickly to the patient. So it does happen, unfortunately. All right.
Did the baby survive?
Yes, the baby did fine.
Mm.
And because the baby was already out, see, it was after we were sewing her up. And I did a lot of cesareans. I did a lot of first assists in the operating room. We were sewing her up, and everything was fine. She wasn't like, having any kind of hemorrhaging or her, we didn't see any of that when we were sewing her up. And then all of a sudden, she started having stress.
Mm. Oh my
And it
God.
was, I'm going to tell you guys, it was just a matter of seconds, and this
Mm.
lady was gone. Yeah. So unfortunately, things like that can happen. So of course we got the code team came in, and we tried to resuscitate her, and we tried everything, you know, and couldn't. And the father, the husband, and the baby went to nursery while we were doing our code on her.
Mm.
So, you never take, like I always told my nurses, don't ever take a day for granted. They'll say, I've done this 10 million times, which, we do, but don't ever take for granted, because the day you take that for granted, you're not paying attention, it's going to kick you where? It's going to get you. Okay. So, you always want to be on alert to everything. You always want to be thinking, you know, what's happening with my patient, what's her vital signs, what can I anticipate, is she bleeding, is her fundus firm, is she going to the is she getting if we going to the bathroom, is she emptying her bladder, you're always thinking, what's her lochia look like, is it rubra, is it, how many, does it have a large clots, things like that. You always are thinking, because you're always what want to make sure that we prevent something. Such another thing on postpartum is that you can throw a DVT very easily, a deep vein thrombosis. So that's why we do the Holman's test on postpartum, to make sure that she doesn't have any pain in her legs. So that concludes this chapter 8, nursing care of women with complications during labor and birth. And we also did chapter 7. We talked about pain management, which was basically looking at the epidural and what complications associated with an epidural is hypotension. Mom's blood pressure goes down. So we'll give her fluids before the epidural so that we don't have that. Because when mom's blood pressure goes down, baby's heart rate will go down. Believe me, I have been in the early part of the epidural, when the epidurals first came out, and they used to give them, like, take a big syringe, a 60 ml syringe, and they used to just push it through the IV, and my patient's blood pressure would always bottom out. Oh, yes. And a fetal heart rate. I would have to flip the patient from side to side, try to get the fetal heart rate back up while I'm giving her fluids. And it was awful in the very beginning with epidurals. But they have made big strides in the labor room with epidurals. We have beautiful pumps now. It's all regulated, and lovely. It's done very well. Where we can, when the patient becomes 10 centimeters, we can let anesthesia know that my patient's 10 centimeters. So now we can back off a little bit so she can feel a little bit of pressure in order to push effectively. Because one thing you hate to see is a patient pushing and she's not even pushing in the right place. So a lot of times I would take my fingers and I would do some perinatal massaging, and I would say, can you feel my fingers? And I would be right there down the perineum, and I say, do you feel my fingers? And if you can, then push my fingers out. And if they push my fingers out, they're pushing the baby. And another way I got my patient to push effectively was I said, okay, think of yourself on the toilet and you're being constipated for 2 weeks. Oh, you're miserable. And they usually, well, yes, I am. And I said, now you want to push that stool out. So you're going to have a big bowel movement. Push down like you're having the biggest bowel movement of your life. And I tell you what, that works. So again, L&D nurses, we do what we have to do to try to get our babies out. And so it works, because mommy now was thinking that. See, before I had patients that would push in their neck, and of course their veins in their neck would just stick out. I go, nope, you're not pushing the right place. And you don't want to waste pushing, because you can make your patient very exhausted. And then they lay there and they say, okay, I'm done, I give up. And you say, you can't give up. No way. We're almost done. We're almost ready to have this baby. And I need you, because I don't want to use forceps. We talked about, I show you the picture on forceps. You don't want to use forceps. They're stainless steel, and they are hard, and they don't give. Okay, so when you put it on a baby's head to help, and they're helping. I mean, mom's pushing and they're pulling. they can cause sometimes facial paralysis, and then they have marks on their head. You don't want to do that. So you try not to. And the other alternatives is someone who says, oh, I can't push anymore. That you can use the vacuum extractor. Now, vacuum extractor is circular, and they put this little vacuum on the baby's head. They don't put it on the suture line. No, 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 no. They put it on the side of the head, and while mom pushes, there's counter pressure, and so we got the pressure on, and they're actually assisting the baby come out. That works really well, but you have to be careful because you can cause the cephalhematoma to the newborn, which is a collection of blood under the scalp, which is usually, if you see my head, is on the side of the scalp of the head, right here. Okay, now heads up, I'll give you kind of hint for the future. Cephalhematoma is on where? The side, right? Now, the other one is called a capsuccedium. And that one is like right here. See my head? I'm drawing the circle. It's right in here. See? And you see the baby suture line would be right in the middle, right? Okay. So that one crosses the suture line. Okay? So write that down. Capsuccedium crosses the suture line. And
How do you spell that?
Huh?
How do you spell them?
I knew you were going to ask me that. So let me see. Caput, C-A-P-U-T, and then succedium, S-U-C-C-E-N-D-A-U-M.
That's at the back of the head.
That one, no, that one is right here.
On the top of the head, right? Like the cap, the crown.
Right here, right where my fingers are, like here, right here. And you see, now the baby would have suture line that you would see, like right here. See here? Right down the middle. So this caput succedium crosses the suture line. Okay. Now, everybody got that? So now, the other one that I want you to remember is called a cephalhematoma. That's C-E-P-H-A-L-O hematoma. And that one is on the side of the head. See where I'm pointing?
Yeah.
And that's a collection of blood under the scalp. So they both go away, thank goodness. But when baby comes out, they look kind of funny. And so mom will go, oh my goodness, what's wrong with my baby? Nothing. It's just that when they either use the forceps or the pushing or the vacuum, that's what happened. But it goes away. So I usually reassure mom. I let her
You can like shape it, right? Like rub it in a circle, rub the head in a circle.
Yeah, and I say it'll go away. It's okay. But I let them touch. Yeah, and they do. And then I said, let's put a little cap on. And so and before you know it, I mean, it goes down. So then they're reassured. But I don't blame moms. I mean, it can be very scary to a new mom. But again, that's why we try to coach them to push effectively.
Right.
And there's another, birth problem we can have is shoulder dystocia, where the shoulders get stuck. Yeah. Oh boy. These are big babies that, guys, let me tell you, you're in the delivery room and the head pops out. We got the head out. We go, okay, that's good. I never breathe again until that shoulder comes out, because the shoulders are wide. And if you have too big of shoulders, too wide, then we can get what we call shoulder dystocia. And so there's nothing I can do. I can have the lady put back her legs all the way back to her ears, which we do. So tonight I'm in your bed. Just try to see if you can put your legs back to your ears. And that actually opens up the pelvic floor. And what happens is I try that and it still doesn't come. So here you are, you're delivering this baby, and the head now is kind of turning like all different color, purplish and blue. I go, oh God, I gotta get this baby out. The only alternative I can do is go in and snap the baby's clavicle, and then that releases the shoulder, and then I can get the baby out. It's not good. It's not good. It's a complication. But the baby's bone, I'm going to tell you, after delivery, we kind of put in position, and we can make sure that it's like a little, what do you call, a handkerchief, position there. And then they heal very quickly. But you had to get a baby out, because once the head is out, there's no turning back. You can't push it back up. You got to come out. So you have to try, to do all those kind of maneuvers. So those are some more complications that can happen. So I think we did pretty good on everything. Try to, of course, read the chapters, and then do that scenario that I gave you. Okay, it's good. I wrote that myself, and so I want you to. And I took out all the highlights from the chapter, and I put it into where I wanted you to imagine yourself now as the prenatal nurse. And when you're confronted with a patient and they're sitting right in front of you and they're asking you these questions, you've got to know it, and you've got to be able to say it and reassure her, so that at the end she feels, "Gee, nurse, after talking to you, I feel so much better. Thank you." That's all that you want to do. Okay, so I think I conclude today, and keep reading. Happy reading, everybody. So let me go ahead and stop recording.